All right. Good morning, good afternoon, depending on where you are. Good evening to our friend Deb in Australia. Is that correct, Deb? Is it evening there?
It's 1:30 a.m.
It's 1:30 a.m. What?
Mm.
Wow. That is dedication. She's a party animal. She's up at 1:30 doing all things academic detailing. That's the dedication we love to see. Everyone say hey to Deb from Australia. Welcome, everyone. It's so lovely to see you all. I'm Bevan. You all know me, and I'm here with my fearless co-pilot, Vishal Kinkabwala, to whom I will introduce you in just a moment for those of you who have yet to have had the pleasure to meet him. He has just dropped in the chat box a link called Today's Summit, the agenda, the program book, breakouts, everything you need to know, and we will continue to drop it throughout so that you have it. But it will have everything you need. It is our virtual guide. It looks just like the image on the right. And within this program, it has session descriptions, links that you can click on right in the virtual program book. But if you have any questions about it, do let us know. And without further ado, I would love to say good morning, good afternoon, good night, and good luck. I'm the deputy director here and your summit co-host for the next 2 days. And also representing NARCAD is the wonderful Vishal Kinkabwala. Vishal, over to you.
Hello, everybody. So excited to be here. And most of all, so excited all of y'all are here. We're about to have so much fun these next 2 days. So super, super amped. My name is Vishal Kingabwala. As Bevan had said, I am super excited to be a training consultant facilitator here with NARCAD, as well as working with the Michigan Department of Health and Human Services in lovely Lansing, Michigan. Although lately 90 plus is not quite so lovely. But we are super excited for the next 2 days.
We're so glad to have you, Vishal. Thanks for being here with us and representing NARCAD today. Of course, we have our fearless leader and also our co-founder, Dr. Mike Fisher. Mike, over to you to say good morning and good afternoon to folks.
Hello, everybody. Thank you so much, everyone, for being here. Just absolutely delighted to welcome you to the summit, to our big mid-year event. And you know what's so great about this is just looking around the virtual room is to see people who've been doing this work with us since we started way back 15 years ago, and even before that when we were developing the idea of NARCAD, and people who've started working with us in just the last year or two, or even less than that, and who are just getting ready to launch their first forays into academic detailing. And it's that through line and that continuity with all of you, and a chance to get everyone together virtually for a couple of days that that really keeps everybody's chins up and keeps everyone's excitement level up these days. So excited to spend a couple of days together.
Thanks, Mike, and well said. Yes, we all are trying to chin up right now. We'll talk a little bit more about how we can do that. But before we do, I'd love to say hello on behalf of our incredible Senior Manager of Training and Education, Anna Morgan Barsamian. She is not here because she is on maternity leave. A few weeks ago, she had a healthy baby boy, so she's got two kiddos now. She was very disappointed to not get a chance to see one of her other babies through. The summit is very much her brainchild, and she is pretty single-handedly responsible for inviting all of the wonderful minds here today and tomorrow. So sending good vibes her way. And of course, the godfather of academic detailing. Things would not be complete without mentioning Jerry Avorn, who is our co-founder and our special advisor. He said that he wanted to say hello, and he is unfortunately on the Cape on vacation, but that next year he will tell the Nantucket Film Festival to reschedule their film festival and let us take center stage. So on his behalf, I would love to share a couple of new things that Jerry has been involved in that are quite exciting. And as we go through the next 2 days, you'll see that Vishal and I will be dropping links into the chat You can grab those now, but you can also wait, because at the end of this event, we will be sending you a thank you email with a complete list of every link that we've dropped. So you can sit back, relax, and not worry about having to snag them one at a time. But if you're curious, right here in the now, and you want to click on some of these links, go for it. The first that Vishal just dropped is a Spotify link to Changing Minds. It is our podcast that is now on episode 15. The most recent episode is Jerry talking about evidence being our North Star, which is really something we'll come back to time and again these 2 days and in the days to come. And he talks very, very clearly about ways that we can try to deal with the challenges, the very, very real challenges of the federal government and the impact on our field. So do take a minute to listen to that 20-minute podcast if you like a good podcast. If you'd rather read it, there's a transcript as well. And he also just came out with his second book, Rethinking Medications, Truth, Power, and the Drugs You Take. It was just published by Simon & Schuster back in April. It's a great read, and there's a whole chapter on clinician education. Gets a little shout out in there to NARCAD, and even more in depth into the wonderful workings of ALOSA, our sister organization, and the organization that often sponsors our annual conference. And we also have two speakers, Dominic Trombetta and Paul Fanikos from ALOSA, who will be here to speak in the next couple days. So do check out rethinkmeds.info. It's really phenomenal, and it's an interactive website where you can check in with other readers of Rethinking Medications. It's a pretty cool site, I gotta say. And as Zach Dumont so succinctly puts, my Ramble Fest, it's a banger. So thank you for that in the chat, Zach. All right, some housekeeping. We'll get through this quickly. First things first, if you are able, please turn your video on. If you're not and you need a breather, that's absolutely okay. But when we do things like roundtables for 5 or 10 minutes here or there, or when we do breakouts, it's so key to be able to see each other's faces if that's possible. We do know that Zoom fatigue is real, and so we respect whatever choice you make. And also would love to have this feel as much like the real deal of being in person as humanly possible. Over to you, Vishal.
Thanks. Throughout this event, we will have a chat box that's available in Zoom. Please use that chat box to communicate whatever you need to, ask questions, share any reflections, share any resources. We're open to it all. Back at you, Bevan.
Please ensure your full name is correct on your Zoom window. So if every time you sign into Zoom, it says your organization 124 on it or something like that, please do put your first and last name just so people know how to address you, and your pronouns if you're comfortable.
And if you do have any tech issues or need any tech support, please send us a direct message either to Bevan or myself via Zoom, and we will be right in action to help you out. So first things first, let's talk about this chat box. As you can see at the bottom of your Zoom screen, next to participants, there is the box labeled chat. Please feel free to be sending questions, commentary, thoughts, perusings, whatever it is you may want to talk about in this chat box. We will regularly be checking it. We pride ourselves in being able to answer most every question that comes in. If for any reason we are not able to answer your questions, we will be sure to follow up on everything not addressed in an email. So please don't be shy. We love to hear it all.
Yes, and please share resources with each other from past conferences that are virtual and summits. We've had folks ask questions like, is there any research on that? And inevitably someone will pop in, check out this publication. And so that's always lovely to do. And anything you drop, we will include in the final list. And also, whenever you see this slide, that is the slide that will come up at the end of presentations as a dedicated Q&A segment. So as you know, this is all being recorded, so no need to take copious notes unless, of course, you like to, and we support you with that. But you will have access to all main session recordings, slides, and any additional materials that breakout leaders included, such as worksheets, links, and so forth. So stay tuned for the summit recordings and materials within 1 week from tomorrow. All right, so what are we going to be getting into in the next couple of days? Well, we're going to be talking about the tough stuff, the real world struggles that you all are facing, not just as members of the detailing community, but I know some of you wear many hats, are working in maybe public health departments that have been deeply cut in terms of budgets, staffing, and so forth. We're going to be sharing resources and ideas to find ways through this time. And again, getting back to this idea of evidence as our anchor, evidence as our North Star. You're going to hear that a lot over the next few days. And we're going to talk more about what that means in just a moment. As always, we are incredibly dedicated, as I know are all of you, to standing up for vulnerable populations, making sure that the work you're doing is impacting the folks that need it most, whether you're detailing in Oklahoma to support folks who are on Medicaid, whether you are detailing to ensure that maternal health for immigrant women is being supported, is being seen. These are all incredible and noble subfields to be focusing on, and people who are real people that need our care and need our support. And of course, we're going to be talking about our theme, which is cultivating community and thinking about community in myriad ways. We'll talk more about that in just a bit, but on the whole, we really want to emphasize and find ways to tap into community resilience, especially as many of us are drained, exhausted, confused, and feeling, like, what do we do now? So we'll talk practically about the things that we can do to try to recharge ourselves. Vishal, what else do we have going on?
We're going to be talking about health disparities. That's the name of the game, the why for the work that we're doing as professionals in the healthcare world. We'll also talk about unique academic detailing sessions or settings, excuse me, because as we know, and what I love to say, there are no cookie cutters that exist here in the world of academic detailing. So that goes to locations as well. We'll be talking about empathy building. How do we build and how do we maintain that empathy for all situations in the face of these struggles that we're currently facing? Building collaboratives, it's really about the networking and the building of any resource, any relationship, any infrastructure there, really the how to make things happen. We'll be talking about novel applications. We're always excited to be searching for that new thing, that exciting new thing on the horizon. We'll be going into how that works. And of course, patient detailing, because that is actually something that is novel and exciting as well. Detailing is not just one size fits all. Really, anyone we're able to detail, there's some wonderful applications that I personally am really excited to hear more about and much, much more, including your contributions right there. We cannot wait to hear them and dive more into them.
Absolutely. So please know, those of you who've been to our virtual convenings before know that this is not a space where we want you to feel like you're just listening to a webinar that could be recorded. We want you to feel like there's a reason that you're here live with us. So there's major opportunities for interactivity and turning to each other to learn, to come up with creative solutions, to talk about challenges that you're just left really scratching your head about, to walk away with tangible skills, to say at the end of tomorrow, hey, I have something new I can bring back to my program and apply. And of course, to network with each other, because at the end of the day, you are all the leaders in this field. What you are doing, the novel applications that Vishal just spoke so excitedly about, those are the things where we at NARCAD look to you to tell us what's happening and where we should be focusing our attention and highlighting the work in the field that's so important. So we're in the middle of our welcome and kickoff now. We'll soon transition to opening remarks and a quick networking roundtable. For those of you who hate networking, it's going to be simple and quick and as painless as possible. We're just going to have you turn to each other and talk about what keeps you going and what your core values are as a professional, as well as what we think patients value most. And by defining those up front, we'll really have a compass for the next 2 days. Then we'll move into a wonderful presentation talking about elevating the voices of people with lived experience, people who are dealing with stigma. Very awesome presentation that I'm excited to tee up in just a little bit. We'll take a 30-minute break, and for all breaks today, just shut off your camera and audio, but stay connected to Zoom. After that, we'll move into program development workshops, which we'll tell you more about in a hot second. We'll take another 15-minute break, and then we'll wrap up with a special presentation called Building Bridges. And those are creative collaborations where AD is a key component of a larger initiative, or an initiative where there are dual approaches or multiple arms to find ways to improve the quality of care. All right, so Vishal, let's talk really quickly about our workshops for today.
I'm so excited to do that. We got some awesome workshops today. They're going to be a blast. First one we have there is actually really exciting one from some fellow Narcadians, Bevan and Amanda, on high impact, low cost, building quality AD interventions on a budget. Now you got me listening.
Yeah, we know that some folks didn't used to have to think about budgeting, but they do now. We also have a wonderful presentation 2 here in purple from the Rutgers crew, Latricia and Amir. It's called Mobilizing Community Networks to Drive Sustainable Change. If you want to learn about learning collaboratives and how to build them, that is the breakout session for you. And you'll see that Vishal dropped the program book in the chat just a few moments ago if you want to look more closely at that. And last but not least, what do we have?
Finally, we got Celebrating Community Identity to foster resilience and engagement with our awesome friends over at Dish AZ in Arizona. They got some sunny skies and some great content coming our way.
Any presentation I've ever seen of Dishes has had my mind really, all the wheels turning, which is something that, you know, really, really matters these days. We need to be thinking outside of the box. All right, so let's stop yakking and turn it over to you. Pop over to your chat box. We're going to do a little bit of waterfalls. What's been the hardest thing about the first half of 2025 as it relates to your work in healthcare? I know that if we do more broadly, it could be a million things, but if we focus on professionally, what's been the toughest thing for you all right now? I know for NARCAD, it's been looking at the state of one of our major funders, AHRQ, and wondering, hey, you know, how are we going to diversify, making sure that we keep running? And I know many of you have similar challenges. I'm seeing layoffs. We lost Ryan on our team. That's from David at Dish. We know that Ryan Anderson, who was working on gender expansive care, ended up having to leave due to cuts, which was heartbreaking. What a wonderful detailer and a fantastic human being. So losing staff members, that's something that really can shake you up. We also have general uncertainty, fiscal uncertainty, finding continuous funding, rampant misinformation. Amanda, we're going to talk about that in just a moment. The administration and the financial status of my program. So a lot more about just general uncertainty and funding. Alicia from Iowa HHS says the state passing legislation that inhibits our work. Jackie from Oklahoma says not being certain in the historic sources of guidance, CDC, ACIP, etc. It's really hard to plan ahead. The overall attack on science, says Carly Gus. Again, more for misinformation, financial instability, worrying about patients who are unable to afford medications. And Dave from Dish wraps up by saying about half of our AD sessions are helping the people that we serve dealing with their own uncertainty. Thanks, Tina, for the last one. Changing resources, caution, misinformation, all the more need for evidence-based info and consistent messaging. Oh, thank you, Tina. And thank you, Narissa, for representing UIC and Illinois Advanced so beautifully. Just all of the changes and all of the uncertainty are challenging. We do want to sprinkle in a little something to keep us going. So Vishal, over to you for a semi-hopeful way to look at things.
Yeah, so let's take a look at, even though, you know, everyone had some incredible thoughts over there, and it's true, there's a lot that, you know, feels like it's going wrong, and a lot that feels that it's really not quite so great. But at the same time, it's important to find that one thing to hold on to that keeps us going, that one ray of sunshine or sprinkle of hope. Let's more on that. Let's talk about one thing, could be big or small, could be multiple if you have them. what keeps you going during this uncertainty and during all of this confusion? So I'm saying, Devin, having an amazing team at Narcad, I'll vouch for that. Everyone at Narcad is are absolute rock stars. And a kitten, yes, we love our pets here. We love seeing pets, pet interruptions, inspiring colleagues and community from Dr. Fisher. Absolutely. And I feel inspired just being here, seeing all the incredible people that are in this virtual room. Managed to adapt it through COVID. Anything is possible. You right, Jackie. I love the positivity. Anything is possible. We got this. Seeing a
Mhm.
great team working together. Art and cats from Ashley. I love that. Alicia says my amazing team. Oh,
Mhm.
and I think I missed that second part. Amazing team of collaborators, motivation from our team, an opportunity to have an impact. Yes. Keeping the needs
Mhm.
of our patients, Peggy says. I think that's fantastic. Aaron says a
Mhm.
great team and a wedding in September. That's exciting. If that's your wedding, Aaron, congratulations. That's super exciting. David says being consistently there for our clients, even when they change jobs. Yes, exactly. Patients needing our help, having some great teams, working on behalf
Yep.
of our communities, relying on our information, having the
So much
best.
good stuff. Yeah, so much good stuff. Keep
There's
going. Yep.
I love it. So many amazing things. Having the best leaders on the team, regularly practicing gratitude, being thankful for family, health, and the work that we do. Yes, I agree. Practicing gratitude is absolutely fantastic. I love that.
And
Staying
there's
focused on.
science behind it. There's evidence behind it working. So that's kind of nice as well.
There it is, absolutely. Staying focused on the goal, providing education, improving patient care with the side of tiramisu. Yes, that you know what, I
Oh,
gotta one of these days, maybe when we go back to Boston, I'll have to treat everybody. I'm proud to say when I make tiramisu, I hand whip my cream. I'll
oh my
stand there for
goodness.
25 minutes using a whisk to do it. So
Oh my goodness. I did not know that about you. That's amazing. Thank you, Narissa, for reminding us that anything we can do to just keep ourselves going, even if it's a sugar addiction, is all worth it. Thank you guys so much for this and for the continued thoughts about patients and families who rely on us, people who share your values, Carly says. Zach says, hope and faith that with hard work, rational decision making will prevail. And Charlie says, using a whisk for tiramisu cream is the best way. So
hey,
that's important
great.
as we wrap up. And Amir, thank you for saying being optimistic. Sometimes that works for some of us. So keep thoughts going, but we're going to have a few moments to just settle into finding that balance between the things that keep us going and the very real difficulties that we and the larger healthcare community are facing. And I really appreciate those of you that took a moment to talk about patients and families, the impact on them, knowing that the work that we do really is key in showing up for them. And Deb from Australia says, one thing that keeps her going is that AD is still so valued by clinicians and that they're so thankful to have synthesized evidence and human interactions to discuss the evidence in the face of so much uncertainty. 1000%. So let's talk a little bit about the idea of evidence as our anchor and community as our compass. Mixing my metaphors here, but they're both sailing or questing. So let's talk a little bit about the uncertainty. We want to make space for the very painful realities of things such as losing colleagues, losing funding, having, if not losing funding, having restrictions on how you can spend your money. And just in general, seeing the word uncertainty come up so many times, that in and of itself, even if nothing, quote, bad happens, just the shakiness of not knowing can be so disconcerting. Your program being deprioritized is also things that we've heard have come up for folks in our community. I know that for public health departments, there are unique challenges, especially for folks who, as I mentioned before, wear multiple hats. Really taking things that prior to this era were already tight, were already challenging, were already hard to a level that's truly unfathomable. It's insane that saying the word unprecedented really is now precedented. Um, and that with these cuts, with these harsh realities, there's not only a lack of stability, but there's a lack of logic or fairness to the cuts that are being made. that cuts aren't being made, because people aren't doing good work. And so it's overwhelming and it's hard, and it's kind of a moment where it's okay to, stamp our collective feet and say, this isn't fair, and to acknowledge that we're overwhelmed and some of us are burning out as we try to make things work as best as we can. So right now, let's talk about seeking stability. My good friend Amanda Kennedy from Vermont mentioned that being told to do more with less is absolutely the most frustrating thing to hear at any point, but especially now. So I want to just say that in reality, this is not time to do a SWOT analysis and try to find the gold in this at every moment. We can't possibly jump from challenge to opportunity quickly, especially when the challenge is something that continues to stretch out over time and seems endless. So I want to let you know that it's okay to just find ways to search for even ground. We may be able to, instead of doing more with less, do less with more intention. Go more slowly. Say that you're doing what you can and that that's okay. And tread water until you really feel intuitively or with support that you know what to do next. And I say this because so many of us got into healthcare because we're fixers, we're heroes, we're savers, we love to help. And that can be, while a noble and wonderful and beautiful thing to be, that can be something that sets us up for burnout and for feeling like we are focusing so much on how to try to transform all of this into something positive that it can be almost toxic optimism. So let us make that room to exhale and drop our shoulders and be frustrated. Thank you, Jackie, for chiming in on that. Do less with more intention. Having said that, and I love what Deb said from Australia, we're more important than we've ever been. Not to like give ourselves a huge inflated ego, but the evidence matters more than ever. Having empathy matters more than ever. Leaning on community, building relationships. Every single one of us, even if we are depleted, with what energy we do have, we have a valuable contribution to make. And more isn't always more, right? Less can be more. So let's kind of put our heads together and think, how can we best support clinicians and the patients who really depend on them, especially now with so many patients receiving rampant misinformation, coming into clinics more confused, more agitated, more anxious. How can we best support the clinicians whose patients depend on them? And we can do that by centering ourselves on what we know works. Let's talk about what that means. So I started thinking about what are some pillars of AD. This is not from a paper. These are my little silly pillars. These are pillars I chatted about with Mike and Vishal and friends in the community. But this is sort of what I wanted to come up with as cornerstones. I keep thinking about how do we ground ourselves. And so we've got evidence, we've got learning, we've got translation, and we've got service. But there are so many more. So I think it's time to kind of take a moment to value and appreciate the richness of what academic detailing is rooted in. So pop on over to the chat. What else would you add if we could come up with more pillars of AD besides evidence, learning, translation, and service? I know one thing that comes to my head is community, guidance. Vishal says connection. Carrie says partnerships, communication and relationships from Narissa. Mike says pragmatism. We've got flexibility, continuity, empathy, connection and empathy, shared accountability from Madison. I love that. Aaron, this is wonderful. Not just empathy, but humanity. I love that. That's so important for us to be thinking about. We've got other words here that are popping up, including collaboration from Julia up in Canada. It really is so important to recognize the human element of AD, that this isn't a walking up to date, that we cannot be replaced by AI, as we discussed a couple of conferences ago. That visibility, connection, and really being there to be of service is something that is so key to the work that we do. So how do we do that? How do we really take not just evidence as our North Star, but also the things that you listed, truly knowing how we can help and best help our clients, says Dave in Arizona. So let's remember what we're good at. We know what good evidence is. We know where to find it, and we know how to translate it to the front lines. So returning to that evidence time and again to support clinicians in the difficult decisions that they have to make. Now, I want to say again, and we know this, patients are being bombarded with misinformation at a rate that is higher than ever. It's the social media piece of it too. This was not an issue about 15 years ago, not to sound like an elderly person. But back in my day, patients weren't looking up on social media whether or not they should get a vaccine. So these are challenging times. Misrepresentations of medical evidence has always happened, but it is now happening from the top down. We have a Secretary of Health and Human Services who is making statements that are factually inaccurate and not evidence-based. And so how do we keep our heads up during that? And really what we have to do is connect with the clinicians who are also struggling with that, and to ask them, what misinformation are you hearing? Can we help with talking points to help use with your confused, distressed, anxious patients who are misinformed? And getting back to what you all shared in the chat box around these pillars, which is focusing on the relationship, providing a space for clinicians to share challenges and the real world impact on their day-to-day practice, and for you to be able to be human and share that as well. And I love what Tina just put in the chat, being intentional. You have invaluable gifts that are so much bigger than just delivering a key message and checking it off, than making sure someone uses a screening tool. It's also about providing space for other folks to exist in their challenges, to invite storytelling from clinicians and share their own personal experiences, which is something that Dish in Arizona talks about so much. Who are you? How does identity matter in how you provide care? You're connecting folks to other resources as well. There are organizations out there that are focused so much on making sure people who are getting their benefits cut have access to food, have access to care. Those are things you can also tap into. And as a detailer, be that conduit, be that connector as a human being with not just compassion and empathy, but expertise and knowledge. We always say at NARCAD, you are the librarians. You don't need to have read every book in the library, but you need to be able to point somebody towards what they need in that moment. So for some of us, connection will do it. For some of us, connecting to things will do it. And for some of us, we're info hungry. The more we can get our hands on better and up-to-date and accurate information and get that in other people's hands, the better we feel. It's time for each of us to really not turn away from this. And I know from all of you in this community that none of you would do that, because we are an organization and a community and a field of integrity. We're here because we're good at this and because we care. And we know that community is critical, especially if you are a small program right now. If you went from 3 staff members to 2, from 2 to 1, and if the one of you that's left is juggling multiple jobs, please, please reach out to each other and to us so that we can support you in seeking that stability. But I want to reiterate, standing still if you need to for a moment is okay. This is a period of time where the urgency feels just unbearable. And to take a moment to care for yourselves as human beings is key, but also to keep asking hard questions, to keep seeking out that evidence, and to know that for every one of you, even if you are limited in capacity right now, that what you do deeply matters. So let's ground ourselves in not just the pillars of AD, but in the integrity of what we each value. And with that, I want to say thank you and transition us to a very quick roundtable. It's actually going to be 5 or 6 minutes long. We're going to do just a power roundtable, and Vishal is going to tell you all what a roundtable here at NARCAD is and what it looks like. Thank you all.
So we're super excited to have our virtual roundtable, which is exactly that. It's our way of being able to reach across the land or reach across the oceans and be able to connect with one another as if we were doing this in person. It's going to be a chat with peers from around the country, around the globe, wherever there may be. We're all sitting at the same table here. It's a chance to ignite this event with energy by exchanging new ideas, being able to vent and air real frustrations, talk about and share our core values, really build those networks, build those connections, find that commonality and that common ground, which will set the pace for our next 2 days. It's an opportunity to bring the best nuggets of wisdom back to the whole group and connect the entire audience together. Because at the end of the day, we really are a detailing family.
I love that, Vishal. All right, so let's talk really briefly about, we've got the tip of the iceberg here, which is what we're able to do, what we're doing in practice, the practices that we carry out. And when what we're able to do seems small or smaller or uncertain or limited, confusing, we have to remember that underneath all of this, we have these deep, large principles and values. And we can invest time in grounding ourselves in these principles and values and share them with each other. We all know what we think we value, but I don't think we sit down and take stock of it very often. So let's take a quick moment to see what matters to us. We're going to pop you over to a chat of 3 or 4 people, and we're going to ask you what your North Stars are. I know there's only one North Star, so just roll with me here. There's more than one star in the sky. What are your constellations? What can you return to again and again, especially during times of struggle? So we're going to ask you 2 questions. Number 1 is, what do I value as a health professional or as a detailer or educator if you're doing that? And number 2, what do patients value? For both questions, which you will have in the chat box in your breakout, you're going to write down as many answers as you can. So I know this says 10 minutes, but we're going to squeeze it into 6. You're going to introduce yourselves in 30 seconds each or less. You're going to come up with what you value as health professionals or health educators, or both. And you're going to come up with what do patients value. Do as many as you can. And again, I'm going to pop these right into the chat box, and you should be able to access those from your breakout. So without further ado, you will see a prompt. Please pop your cameras on if you are so willing and able. We would be very grateful so that you can all make a connection that feels good during this time. And Vishal, let's pop people into groups of 3 or 4. We hope you have a great chat. We will bring you back in just a few minutes. So go for it as soon as you see the prompt coming up.
It should be coming in soon, just having a quick tech issue with the breakout room.
No issues, no worries. And think about it right now while we're waiting to get you in breakout groups. If you had to tell somebody on the spot, what are the 3 things you value most? Would you be able to answer those and really feel like you could explain why? I know that for me, authenticity is huge, being real, being clear, being true to oneself. I know that camaraderie is also huge. And I also know that, for me, just, integrity is key. Doing the things that, that we say that we're going to do, making sure that how we want to be in the world is how we actually will be and how we actually will behave. So sticking to those values. All right, join your room. We'll see you in just a bit. All right. Well, welcome back. We're going to ask you what y'all talked about. All right. So core values. Throw some in the chat. What did you talk about? And if there are any you didn't get to or didn't get to say, you can throw that in there too. All right, Carolyn's kicking us off. Honesty, empathy, accountability, integrity. Yes, we love these.
Collaborative.
Ah, love this from Ashley. Hope, authenticity, empathy, and justice. What else do we have? Transparency. Go ahead. Go right ahead, Vishal.
Love that. We got some honesty, evidence, integrity, and collaboration. Loving to hear these. Got
Yeah.
some integrity, honesty, empathy, protection, like that.
Love that, Sally.
Yeah. Being useful, practical, and relevant, giving people what they need and want. Absolutely. Evidence, ethics, honesty, critical thinking, and care coordination. I think that's fantastic.
We need to bring critical thinking back.
Absolutely. Right? Equity and access, really the name of the game and the work that we do. Absolutely.
Yeah, love that, Ezra. Love that.
And lots of trust in
Yeah.
evidence base, trust in being heard.
Trusting relationship that the clinician can count on, evidence more for clinical reasoning, staff support, patient needs, being client focused. Love all this. Trust in being heard. Wonderful stuff, guys. All right. What are patients' core values? And obviously, you're not guessing on this because you've been and are a patient. So also, what do we think are the things that patients value the most? Pop those right on into the chat. Would you come up with? Truth, reliability, empathy, eye contact. Love that. Being heard, engaging in conversation and action, evidence-based practices. Love that as well. Feeling empowered to contribute to decision-making. Yeah, a sense of agency. Love that. Trust, autonomy, providers who listen without rushing them. That is wonderful. Clear communication, compassion, fearlessness, judgment-free, trusting relationships, shared decision-making. We love that too. Translation practices, interpretation services, services in the language that the patients speak. Yes. Breaking down clinical lingo, right? So considering health literacy, that we as clinicians collaborate and read each other's notes. We love that too. And all stuff looking good. Yes, we love this so much. Thank you. And love to wrap up with Hezra's that says, making me feel like I matter.
I love that one.
Because patients do. And so that's the work that we're doing. And that's the importance behind making sure our connections to the clinicians that we detail are strong, making sure that what we bring to those relationships translate into the relationships between clinician and patient. So without further ado, I want to say thank you all for participating in that. And I'm going to transition to this next slide, if my computer would like to do what I'm asking it to do. And as we prepare for this presentation, I'm going to turn it to Mike to introduce this wonderful duo, Darla Peterson and Mary Hightower from the Iowa Health and Human Services Group. They really are phenomenal, and they will be talking about elevating the voices of people with lived experience, which is so key considering what we all just talked about. So Mike, over to you. And Mike, you are muted.
I am muted. I was still enjoying clicking around in the chat so much from that wonderful wonderful discussion that we had. But really excited for this first presentation. As Bevan said, we have two colleagues who are joining us from Iowa. Both of them are regional health specialists in the Iowa Department of Health and Human Services Bureau of HIV, STI, and Hepatitis. And let me tell you just a little bit about each of them, and really just skim the surface of their many accomplishments, because we really want to get to hearing from them about their work. So Mary Hightower Mary had a background with prior experience in grant management and health education with the Southeast Iowa Adolescent Pregnancy Prevention Coalition, Planned Parenthood of the Heartland. But over the past 8 years, she's been in the public health role where she's worked with healthcare providers, community stakeholders, really focused on promoting STI testing, treatment, and education. She's been connecting stakeholders to resources for HIV, facilitated access to care. She's been advocating for the uptake of PrEP while addressing the stigma that can be prevalent in the communities she served, all of which is so relevant for the presentation that she'll be making, along with her partner joining her on the virtual podium here, who's Darla Peterson. Darla's got 32 years of experience in this field, working with HIV, STI, hepatitis. Most of it's been spent managing an HIV program in a federally qualified health center, so really used to being on the front lines of healthcare. For the last 9 years, she's been working to connect folks with resources, stressing the importance of sexual health assessments, also working on PrEP uptake. She's been involving people with lived experience to provide meaningful input into addressing stigma. And with those backgrounds, that amazing body of work that the two of them have put together, you can see why they're the perfect duo to share with us about the power of we, elevating the voices of people with lived experience. So let me hand the virtual podium over to Darla and Mary.
Thank you so much, Mike and Bevan and Vishal. What a wonderful introduction. And Darla and I are really excited to kick off the presentations for the next 2 days for NARCAD's virtual summer summit. So thank you so much for having us. My name is Mary Hightower, and I'm a regional health specialist working on behalf of the Bureau of HIV, STIs, and Hepatitis here in Iowa. And I have my lovely friend and colleague, Darla Peterson, who will be co-presenting with me today. And so I really want to, if we could go back to that first, our introduction slide. Today we're going to be discussing addressing stigma by involving people with lived experience. And it's important to include their voices to educate the providers and our stakeholders that we're working with successfully. So we're really bringing the people with lived experience with us. And I wanted to go back to our intro slide because, as you can see in this photo, it is a picture of folks from our wellness summit, so for people living with HIV in Iowa. And their perspectives are central to our work and guide us in everything that we do from start to finish. So seeing their smiling faces in the beginning of our presentation is so impactful and important because we are working on behalf of them. So we start this presentation with those folks. Next slide, please. And so where it all began, our journey working with individuals with lived experience is because they requested the regional health specialist to include them in our work, to bring them with us in our detailing sessions with our providers. So it was a unique opportunity that they requested us to support them and to bring their voices with us in our detailing work. So it's really unique, but also so amazing that we had that ask from them. There are 5 detailers that are working in Iowa, and they all are on our call today. So welcome to my team as well. Our focus is cultivating the workforce that will end HIV, STIs, and hepatitis-related health disparities in Iowa. And we've also formed an anti-stigma group to discuss HIV and STI-related stigma. So what can we all expect today? We are going to talk about the value of lived experience in healthcare and the AD work that we're doing. We're going to bring you real examples from people impacted by HIV and substance use. We will talk about how academic detailers can use these voices in the work that you all are doing. We'll provide you with some tips for creating more person-centered conversations. And we are going to be doing chat waterfalls with the help of our lovely Bevan and involving you all as participants because, of course, we love group participation. So speaking of those waterfalls, we have our first one. And these chat waterfalls are ways that everyone can express their thoughts on specific questions. So each chat waterfall will have a specific question. And Bevan is going to give the go-ahead. But what we'd like you to do is first, this topic or this chat waterfall is asking, what topics do you detail on? And we'll give you a chance to think about that and then respond in the chat. But I'm going to let Bevan go ahead and step in and sort of facilitate this. But what we'd like you to do is respond in the chat to this question, and we'll give you the go ahead and we'll kind of answer some of or see some of those responses.
Wonderful. So what topic are you detailing on? And if you don't have a topic yet, what do you wish you were detailing on? So we've got HIV, Hep C, gender affirming care, harm reduction, controlled substances, pain management, opioid safety, chronic disease, stigma, ESPER, diabetes, hypertension, kidney disease, opioids, hypertension again, lipids, hepatitis, anti-stigma, SUD, community health work, COPD, dyslipidemia, kidney health in patients with diabetes, prescribing stewardship, alternatives to opioids, minimizing opioid prescribing, ADHD, MOUD, naloxone prescribing, looking at benzo and opioid co-prescribing, a few more here, stigma, OUD, HIV, PrEP, NPEP, TB, tick-borne illness, STIs, New Hampshire's Ryan White Care and linkage to care, and AFib and COPD. That's just a few. So what a rich field of work you all are working on. It's really phenomenal to see. Back to you, Mary.
Yes, thank you. Wow, lots and lots of different AD work. And the tick-borne illness is a new one for me, I think. So that's very, very cool. And if we have a chance to learn more about what that AD looks like, that would be cool to chat about. But thank you all for your awesome responses and the work that you're doing. So these next few slides that I'm going to show you are examples of how stigma can be really a part of any of the academic detailing topics that we've seen in the chat and that we are detailing on in our communities. And this slide specifically is from a video that's addressing stigma surrounding diabetes. And the video is called The Emotional Toll of Diabetes, and it portrays the feelings and possible reactions of somebody with lived experience. And certainly watch the full video. It's really excellent. The link there is at the bottom. But in the video, this gentleman is living with diabetes, and he has several interactions throughout his day. In the first picture, he is at work enjoying a snack, a donut, and a work colleague says, "I thought diabetics couldn't eat donuts." And then later on in the video, he has an interaction with his provider actually. And his provider makes the comment, "Aren't making much progress, are we, in relation to his diabetes?" And then later in the video, he's at home with his partner, and his partner asks, "Have you checked for your blood sugar?" So lots of sort of labeling or possibly stigmatizing encounters that this man has throughout his day. And, you can see in the pictures on the right, those labels really stick with him. And this could be how many people, feel this heaviness, carrying this stigma, these labels with them as they navigate with whatever, health issues. So this is a really great example of providing a slide with some context and information in your detailing work that you can take with you to providers.
And Mary, I love this. I mean, I don't love this, but it's so key. 40% of people with diabetes skip treatments out of shame.
Yeah.
Wow, that is not okay. And thank you, Vishal, for dropping the link to the full video in the chat. We'll make sure you all get that at the end of the 2 days.
Thank you. This slide was adapted from a focus group that discussed stigma and drug use in Iowa. And so I'll just kind of read through it. Research shows stigma is a major barrier for people who use drugs to access health and social services. And so this focus group talked about the 4 different types of stigma. So public stigma, so discrimination from people in the public, stereotypes, structural stigma, so stigma around cultural norms and policies, self-stigma, internalizing their own beliefs, their guilt, their shame that they might carry, and then recovery stigma. So stigma of recovery methods like medication for opioid use disorder. And I like this slide too. It does include a quote from a person who uses drugs, and they shared in this focus group, "I was told it's not worth treating me because I wasn't going to live anyway." You know, what a harmful thing for someone to hear from a provider or another social services or mental health agency in trying to address their substance use. So again, a good example of how you can incorporate focus groups, research, things that are happening in your community or perhaps your health system you're working in, and incorporate that into your presentations when you're out doing detailing. Next slide, please. And this is another survey from Iowa that was done in 2019, and this was a survey with people who use drugs. And the survey shows that nearly 70% of respondents who use drugs reported not seeing a healthcare provider when believed it was important or necessary. And the main reason cited was because of their fear of judgment that they would get from seeing that provider around their substance use. So, and this is another example of how you could incorporate research, data, focus groups, or surveys that have been done in your state or your community into your AD work. Next slide. This slide is from the Recovery Research Institute, and it's showing how stigma and language matters around, again, substance use disorder. So the Recovery Research Institute asked participants to look at both of these pictures and talk about the way that substance use is addressed. So in the first picture, a person was referred to as a substance abuser. And the second picture, the other person was referred to as having a substance use disorder. So this study discovered that participants felt that the term substance abuser was less likely to benefit from treatment, more likely to benefit from punishment, more likely to be socially threatening, more likely to be blamed for their substance use instead of a result of, innate dysfunction over what they couldn't control. And they were more able, maybe they were more able to control their substance use without help. So again, despite the evidence, people continue to use language that perpetuates stigma and its harmful effects. And research shows that words matter. The words that we choose really matter, and they can create these biases, which can affect the person's care and even their treatment when they're seeking care. Next slide, please. So we've included a couple of tools and examples that the regional health specialists use with providers and stakeholders in our communities that we serve. And these next two slides are tools or handouts that we can use. And these are around stigma related to HIV. So they really are focusing on why people first language matters. And so just to give a few examples from stigmatizing terms to preferred and why those terms are preferred. The first is body fluids. So instead of using the word body fluids, the preferred terms are actually naming out the different body fluids that can transmit HIV, because there are other body fluids that don't transmit HIV. So being really specific is important, and being intentional is really important when we're using that people first language. And really being informed helps us foster a more respectful discussion around STIs and HIV. So I won't read them all, but this is a really good example of one of the tools that we can, again, bring with us to our detailing sessions, or we can email to our providers.
And this is wonderful, Mary. I just want to say that we at NARCAT learned a lot about this, that saying that a group is higher risk even, or that high risk behavior is an incredibly stigmatizing thing to say. And so, we get a chance to learn from you all and learn from those of you doing this work in the field every day. And we're so grateful for it.
Yeah, and thank you for that. And honestly, asking people with lived experience, what are the preferred terms, that we can share with the providers that we're seeing? What language can we share with them that is preferred by you, right? Because again, and Darla will share this later, but we always say nothing about us without us, and so we want to make sure that we're asking those questions. And this is just another example of one of those tools that we use. And this is a tool that we can give to providers that distinguishes between stigmatizing language and non-stigmatizing terms. So again, just kind of pulling from the top, stigmatizing terms could be HIV infected person, victim, sufferer. And the preferred terms are persons living with HIV, or you might see that acronym PLWH, survivor, warrior. And again, this is, we're emphasizing the person and not their diagnosis, which is really important. So when the regional health specialists, when we're out promoting People First language, we are very mindful that we are modeling this People First language to our providers and our stakeholders. So we are modeling what we are showing them. Okay, we are on our second chat waterfall. So hopefully we're all familiar with how this is going to roll now. So this chat waterfall is asking, what People First language do you use in your focus topics? So maybe you use kind of similar terms if you're working in HIV, STI detailing. So take a minute to think about what People First language that you use, or maybe you haven't thought about it and now is your opportunity to say, well, this is something that I could say. So please go ahead and fill that chat up.
Love that question. It's so wonderful. And, Julia kicks us off with people living with versus suffering from. That's a really interesting thing to talk about. And Julia, I'd love to unmute you for a hot second. Can you speak a little bit more to the importance of that difference?
Well, I think just even the connotation of the word suffering, it means that someone is being very negatively affected by their health condition, and people can live meaningful quality lives with a variety of different health conditions. So I think being sensitive to, oh, they suffer from diabetes, people can not suffer from that condition and be very healthy.
Very important to bring up. Thank you, Julia, for letting me put you on the spot. We have other folks who are very much behind the person who uses substances piece that you brought up, Mary. People of trans experience, that is a new one as well. Dave, can I unmute you for a quick second to speak about that? I know you have a ton of expertise in that area, so would love you to share a couple of thoughts about that approach to language.
Yeah, sure. It was something I learned from Ryan, one of my teammates. So he, just like when we say a transgender person, people are more than being transgender, right? So just like that is part of their experience of life, not all of who they are, right?
Not their sole identifier.
Not exactly.
Yeah, that's wonderful. Thank you for sharing. Elizabeth from Maine shares people who use drugs or people who inject drugs. Yes. Tahira from Canada says people with diabetes versus a-diabetic. Amy from New Hampshire says, I try to use it all the time, this people with or a person living with. So really literally putting that person first. We have some backup support on that from Amir. Individuals experiencing homelessness or a person who is unhoused is something that I've also heard. We have from Deb in Australia, asking a person directly their preferred language around weight. That is very important. We have a couple more, a positive drug urinalysis or unexpected urine findings. Not using high-risk people, but instead people who may benefit from PrEP. Saying older people versus elderly. and saying risky drugs versus risky behavior. Jackie, would you like to wrap us up speaking a little bit more about some context on that and using that language? That would be really great.
Yep, sure, absolutely. And so, as I said there, I totally stole that from Amanda Kennedy. So, hat tip to you, Amanda. Yeah, it just speaks to the universal nature of what the risk is. It's not specifically about a person. A person could be doing everything by the book, and these are still risky drugs, and things still happen.
So the fact that using a drug comes with an associated risk is what the
Yes.
language there is identifying.
Exactly.
Excellent. All right. Thank you all for sharing all of this great stuff. Back to you, Mary. Anything you want to say about that?
Yeah, no, those are all great examples, much appreciated. And I think it's also important to say, you know, it's okay to give yourself grace as well, especially if you've been detailing on a certain, you know, topic or subject for many, many years. Language changes, and we might be used to certain terms when we started versus, you know, language and preferred terms now. So giving ourselves grace as we're providing detailing, acknowledging that no one's perfect, that we even as detailers could make mistakes in the language that we use, and again, just being respectful and mindful of that, you know, asking forgiveness, asking what those preferred terms are. That's exactly how we learn and we improve, right? So again, much appreciated all of those examples. So this is a quote that I used if you were at the NARCAD conference in November. It's such a great quote, and I will continue to use this in my role talking about stigma. But the greatest way to heal the wounds of stigma is to listen, understand, and support those who live with its impact. So we are really excited. Our team is to share or debut one of our videos that we were able to get from members of the pitch community. So the regional health specialists, we attended the Positive Iowans Taking Charge Pitch Wellness Summit last summer. We were invited. And while we were there, we were able to gather videos and member quotes to share with our stakeholders when we're out and about doing our academic detailing in our communities. We were able to work with a marketing company to create short videos that feature specific testimonials on the topics that we're detailing on. So we have several that we can use. One is around stigma, PrEP, so pre-exposure prophylaxis, concurrent STI testing, supportive spaces, improved provider interactions, and test result delivery. And so the video we're going to share with you today is a video around stigma as a barrier to care and connection.
And I do have the disappointing news that the link is not active at the moment. So we will do a snapshot, and Mary will share this quote that was really powerful from one of the video participants. Thanks, Mary.
Yeah. No worries. And thank you, Bevan. And technology, I feel like, is never my friend when I'm virtually presenting, but that's okay. That's why this slide is another great way to share or elevate the voices of folks with lived experience by just a picture and a quote. So the video, this woman shared that professionals, people like doctors and lawyers and disabilities, see my background, my history of drug abuse, and my history of living in the streets. They would see that and automatically wouldn't want to help me. And so this is an individual who is living with HIV, and these were some of the interactions that she had with providers that she would see, who would stigmatize her because of her HIV status. So again, this is a good way that you could bring or elevate the voices of folks with lived experience into your detailing work and it doesn't have to be a picture. Of course, it could just be a quote that you are that you get from someone that you're serving or working with that you take with you. So I'm glad that we also had this example. Go ahead.
Yes. And just want to say, like, oftentimes a picture speaks 1,000 words, right? Because it is a real person. You cannot push those words aside and say, put them out of context. You are seeing a real human being, and that can be really powerful. And I know this isn't the Q&A section just yet, but we have a nice breathable amount of time here, Mary. So
Sure.
I'm wondering if you would be able to share across this sort of this cross section of videos that you mentioned, and all of the titles sound really compelling. How did you find that clinicians received seeing these, or seeing, an individual speak about their situation and the stigma that they had come up against in the past?
And I can answer that, but also I would ask anyone from my team who has also shared any of these testimonials or videos with your stakeholders in your community, any reactions from your providers. I can share that I haven't shared a lot of these videos. We did just get all of them sort of edited and sent back to us, but I was able to share a few with a provider in my area who already did a great job of modeling non-stigmatizing testing and language around HIV. But she expressed how important it was for her colleagues to see these videos and see these testimonials from folks living with HIV, because again, a lot of time, the provider might look not at the whole person, right? Just you're a patient that I'm seeing quickly because of this specific reason, but I might not know the history that you might have around stigma with other healthcare providers. That might be why this patient is hesitant around talking to me about sexual health. So it really brings that patient into focus to that provider and gives more background. And so that's some of the feedback I've gotten from a provider I work very closely with. And I'm not sure if any of my team has other examples from any of the other videos I've been able to share.
If anyone would like to share from Mary and Darla's team, please feel free to let me know by putting your hand up. Oh, Alicia says, haven't shared them yet. So this is a gold mine waiting to be shared, which is so wonderful. And I know we'll all look forward to hearing more about how people in the field respond to them, because many campaigns are thinking about how do we bring a little more technology and a little more of the human aspect and more of patient voice into interaction. So that's wonderful. Thank you for letting me put you on the spot.
Oh, no, absolutely. And again, having providers, we call, rock star providers, right? Providers who really work in tandem with us in the work that we're doing, to be able to share the videos with other colleagues and talk about the importance of why those videos are so important for their colleagues to look at and share with other colleagues too. So again, sometimes it can be that peer-to-peer, right?
Mhm.
Referrals or support. So yeah.
Wonderful.
Okay. So this next slide, it shows the results. This is a 2019 Iowa Consumer Needs Assessment, and this was around HIV-related stigma, and it's based on responses from 555 Iowans living with HIV at the time. So it shows that 66% of respondents work hard to keep their HIV a secret. 78%, which is huge, worry about people discriminating against them because of their HIV status. 33% of the respondents experienced someone physically back away from them when they learned about their HIV status. And 27% said they waited to get tested because of the stigma associated around HIV. So again, many participants expressed concerns about experiencing discrimination because of their HIV status. And we know that stigma, and Darla will talk more about this as we continue on with the presentation, stigma can kill, right? Stigma creates barriers for people to access providers or testing because, as we see in the survey, the fear of bias and shame and other harmful things that they could come across with seeing a provider. And this is another good tool or example of ways that you can incorporate this, these real-time surveys or information from the people that you are working on behalf of into your detailing work. So it can be, again, we've given examples of quotes, videos, but also those responses from people with lived experience, the surveys, consumer needs assessments, focus groups. These are all ways that you can incorporate those voices into the work that you're doing. All righty. This is my last chat waterfall for my part of the presentation. I think we've all got it down now. And this one is asking, what is the most stigmatizing thing you have heard in your work? And if you can't think of something in your work, perhaps it's maybe something that even you felt stigmatized when you were seeing a provider. So go ahead and pop those into the chat and we will see some of those responses.
All right, we've got quite a few here. Julia and I are synced up. Those people, whenever using the term those people, I don't want those people in my practice. Oh, I can identify when those people have an issue. Extremely subtle and also very largely stigmatizing. Problem patients, people who use substances don't care about their health. My Medicaid patients are really just aren't going to change. People from that town coming to our facility, right? So geographic racism and, you know, looking at the ways in which perhaps I'm going to guess that town also being part and parcel of being stigmatizing against folks who have less resources. We have completely stopped all gender affirming care for minors. Oof, yeah, that is tough to hear that. A drug addict who is recovered now. Oof. And often said in a tone that is well-meaning, right? Oh, he's a drug addict, but he's recovered now, you know? So again, that's another thing, the subtle stigma that comes up when it is well-intentioned. People with diagnosed mental health concerns being, quote, crazy or making it up. We have another one about mental health. In a previous career at a psych hospital, Narissa heard the words, "My child isn't schizophrenic. He doesn't need services for crazy people." Is that a lot of internalized stigma? What else are people, or have they heard that was just really kind of, you know, shocking in terms of, and this can be in any of your work as a healthcare professional, but of course, as a detailer, you know, I know Mary, we did a little focus group with detailers 2 or 3 years ago and asked them about conversations they had where they were met with stigma from the clinicians, and it's just shocking, you know, and things like, why do I have to learn to use new pronouns, you know, and things like that. So it's definitely something detailers have to deal with. Mary, back to you.
Yeah. Okay. People who test positive for must provide all partners' names, and just reading a couple more.
Yeah.
Yeah. And I can share one that's still there's several, but you know, working in kind of rural communities in Iowa. And we work, the RHS we work with medical providers, but also non-medical. So mental health, substance use, and community-based corrections. And I was doing some detailing in one of our community jails, and one of the correctional officers made a comment, you know, there's a junkie that we have detained right now, and they deserve HIV because they, you know, shot up drugs. It's something around that. And it was one of the most horrible, stigmatizing, awful things I had heard in my detailing time. And yeah, just, and really, you know, kind of gave you a clear picture of how the detainees were treated while they were there. So just horrible.
Absolutely. And just adding to that, anytime that there's a moralizing of somebody's medical conditions, and particularly all of those folks with us who are working on substance use disorder know this to be true, that, you know, making it seem like it's a choice is really upsetting. And I'm so sorry that you had to hear that. All right, shall we move to the next one?
Yeah, thank you so much, everyone, for participating in those waterfalls. And I am going to pass the remaining part of the presentation to Darla. Again, I appreciate everyone, and I will pass it to you, Darla.
Thank you, Mary. Over to you, Darla.
Thank you, Mary and Bevan. Continuing the conversation, engaging people with lived experience of their disease or condition can help the providers and stakeholders have some insight into what those patients' challenges are, what their barriers are, what they're facing. It can build trust between the provider and the patient because the provider hears their voice. It's possible that some of their patients haven't been comfortable discussing a certain topic, so they may be hearing it for the first time. And it can highlight some of the gaps in care that the data alone can't show. And like Mary said, people may not show up for their appointment, or if they fear being ignored or misunderstood. And we found that out by asking on that survey. Bringing the patient voice can show the challenges stigma may bring, whether it's structural, public, or internalized. And it can help promote empathy when they understand some of these concerns. It drives a more responsive, inclusive health solution for the patients. And it could encourage listening and conversation, more chatting about what next we're providing for this patient. They can work together. And our favorite one, the most important to us, is ensuring that the people we are representing feel included. That even if they're not there with us presenting, we're bringing their words, we're bringing their voices. And it's been very impactful. I have presented and showed, I know we just got these videos, but I have been able to get into a few offices and show these videos, and it's been very impactful. There's a lot of looking like they could burst into tears sort of things, and just meaningful conversations that we have. So it's been great so far. Next slide. Some of the ways to involve people with lived experiences. This is very unique to our program. We have to admit that from the very beginning, people living with HIV actually asked Health and Human Services in Iowa to hire academic detailers to discuss HIV, STI, and hepatitis in our communities. And so that's pretty unique to us, but it's pretty exciting. And that's why we keep involving them. First, you have to find the people in order to involve them. Where are you finding them? We found them through case managers and advocates, and through our work with Positive Iowans Taking Charge, we call Pitch. We've met with Pitch individuals at their monthly meetings and asked for their involvement. You'll have to figure out where you can find the people. We have an anti-stigma committee, Mary mentioned, and we have people with lived experience on that committee. Because why would you have an anti-stigma committee and not invite the people who are most stigmatized by that disease? So our next project, one of our great colleagues, Ashley, is working on a speakers bureau. And so we will be having individuals actually go with us to our AD sessions or our group sessions, and whether it's virtual or in person. And those people will be given an honorarium for their involvement. So we're really focusing and working hard on this so that it comes out right. And we're asking involvement from the patients as well. And those involved in the videos that Mary talked about, they received honorariums as well, which is very important. So another way you could access people, though, is you could ask mental health therapists to gather some quotes for you from patients. If you're seeing a couple of nurses next week, you could ask them to gather some quotes from patients. How good was their care? What was involved in their care? What could be improved? And then another thing I have to mention is NARCAT has been wonderful, and we asked for their input. We were asked for input on an exercise NARCAT taught us back in November in Boston. They said, ask yourselves, your team, what are the patient concerns when they see a provider, and what are the challenges that a provider has, and what tools do we need to support the provider? Well, we turned that around. We did that work, but then we also put it out to the patients. We want to hear from you, and we did a whole jam board on their responses, and that's the work that we need to do then, is what they came up with. So it's pretty exciting to tweak it and turn it around. And we use the quotes then in our AD visits, and then they could be invited to advisory boards. We invited people to our anti-stigma planning team and community meetings. Think about that. We go to a lot of community meetings to talk about our issues, and bring that focus to the communities, but also to try to find more people to present to. And so it's very important to make sure that we involve some of them in community meetings. And then asking for feedback on provider messaging or your handouts, your fact sheets. What makes sense and what doesn't? What did we leave out? What do you think we should include? And I actually, when Mary and I talked to the pitch one night at one of their meetings, I said, this is how I talk to providers and encourage them to do a sexual health assessment. And I ran through the whole thing. I said, what do you think? What is your input? How would you do it differently? So that sort of thing is a really great approach to ask for their opinion. And then again, we did the short videos. May not work for you to have professional videographer, but you could use a smartphone or the patient's smartphone, and they could just grab short videos as well that you could use later in your conversations. Next slide. So this, I'm going to continue to talk about the quotes and other things that we've been using besides the videos. So here's a quote from a patient that I really enjoyed this quote because it's kind of messy, but this is her answer. Don't be afraid to have the conversations. Listen, substance use, sex, abusive relationships, how long have they done it? And be okay with their response. Make referrals to other agencies to get their needs met. I thought that was pretty powerful that one lady told us that. I have another quote that I wrote down here, but it's not on the slide. One individual, a nice gentleman, said, try to be sympathetic and listen. You keep hearing that, listen, right? Don't do the quick come in and talk and then leave. Like really listen, because a person living with HIV is different. And sometimes they need a little bit more care and someone to actually hear their voice instead of you telling them. It's an emotional battle as well as physical. So just have a little patience. You know what I mean? I love that quote. We know providers are busy and they don't always have a lot of time with a patient, but look what it meant to that patient. So some people we mentioned didn't want to do a video, and some of them made masks. And I have one, everybody has one, all 5 of us have a mask that we can bring. I'm about wearing mine out. So sometimes I'm using it now as a picture like this on a slide because I'm wearing out the mask. So an individual that did not want to participate in the videos made this mask for us. He says, life is a dichotomy for all. This is especially true for long-term HIV survivors. The contrast between 1985 and 2025 is immeasurable. And so what he has on one side of his mask in that red area, he has nausea, vomiting, death, fear. And then you move over to 2025 and he has acceptance, life, love. Things are a lot better for him. But I want to note, I wonder if there's any stigma for this fellow today, because after all, he did not want to participate in a video. So I think that still shows some stigma there. I bring this with me and I say, I bring you the voice of the patient. And it's pretty powerful. It can really start a conversation. Next slide. I also have a rock, and pretty soon, if not yet, pretty soon all of our detailers will have a rock. So an individual with HIV made this rock, or didn't make the rock, but painted it. And she wrote Stigma Kills on here. And it's kind of a heavy rock. And so I've brought it out to presentations. And one time I had 32 people in the presentation, like we said, we don't always do one-on-one. And I had 32 people in the presentation. I was talking about hepatitis C, which also carries stigma. But in the middle of my presentation, I said, could you pass this around? And they looked at me like, okay, what are we supposed to do with it? They passed it around, they looked at it, they touched it. Some people turned it over. They brought it back to me. When they brought it back to me, I said, I wonder what that person meant. What did she mean by stigma kills? And then I said, could I come back for another conversation on a different day and we talk about stigma and how it impacts your work? And so I can use this. I've also used it in absolutely a focused topic just on stigma. So it's a great topic for that. But it's also great for a teaser for, I'm talking about hepatitis C and all the stats around it, but how about I come back next and talk about stigma? And I have to thank Rocco and the Arizona group because I got that idea of teaser from them last year. And I love that, bringing a teaser and saying, hey, I can talk about something else. Instead of just having a list of things you could talk about, bring the rock. And so we're going to do this chat waterfall. I'm really interested in hearing what you say, so be thinking about your answers, but I have an answer first. I read a lot of books, and I just read a book by Frederick Bachman called My Friends. And there was a quote in there that I'm moving to be the answer to this. The quote said, "Nothing weighs more than someone's belief in you." And I say, could we perhaps make that the belief in someone weigh more than the stigma?
A positive belief.
Yeah. And so I'd like to hear what you think the weight of stigma is.
All right, everyone. What's the weight of stigma? What comes to your mind when you want to answer that question? Don't think too hard, just free associate. Someone asked you that question, what would you say? My brain goes right to shame. The weight of stigma is shame, and shame is so incredibly heavy. It's such a burden. Zach says heavy. Amy McQueenie says not getting care, soul crushing, silent killer, depressive, illness, lonely, separation, suffocating, activation, radiating, bias, feeling both unseen and misseen, belittling, more for fear and isolation, unheard, depression. Yeah, this is tough. This is tough stuff. Alone. Yeah, it's really powerful to see all these words together. It's like a very sad poem, and hard to lose despite all of the efforts. It's verification of every bad thing you've ever thought about yourself. And then also fear, just straight up fear. Thank you guys for sharing that. Keep them coming if you would like. Back to you, Darla. Oh, you're muted. And we see loss of hope as well. Thank you, Tina.
I always say after I've passed it around and showed it and asked people what that means, I always say, it's heavy, isn't it? Because that rock is kind of heavy. So I say, that's heavy. So it does make a good teaser to talk about stigma next. Next slide.
The tangible, having an actual item in your hand seems really powerful.
Yes, to show the weight of it too. And it just is impactful then. It's kind of a little dramatic. Okay, so we have another chat waterfall here. I would like to hear, what are some ways you could access or incorporate patient voices into your AD work? We talked a little bit about how you might be able to do it. How are you doing it already, or how do you think you could do it?
Yeah, how might you want to do it? And try not to think too much about resources right now. Just think about, if you had nothing in your way, how would you acquire and incorporate the patient voice into your AD campaigns? And this is a really layered question, so we'll give you a moment to think about it. I love what you all have shared so far, Darla and Mary, about the idea of just getting people speaking and recording them. That's something, if you have the resources to do. Dave says, test out educational materials at a support group for people living with HIV. That's wonderful. Ask them, are we on target here? Are we representing you well? What's your feedback? Julia says, have patients review our materials as well. Ask them what their knowledge gaps are. What would they like to know? Christine Fishman from Ohio says, remembering that they are part of the why for our work. So even just bringing in that energy. Amir says, distribute patient surveys at the doctor's office and facilities. Yes, those patient survey responses were incredibly powerful when Mary read them aloud. Heather says, share patient experiences with providers to demonstrate the impact that their word choices and stigma may have on those patients. A few more for video testimonials about their struggles and barriers for care between visits. That gives the needs a face. I love that, Tina. Share patient voices with all staff. Share stories of when maybe you've made missteps caring for patients and the impact. And Lauren wraps up by saying, what's missing? Ask patients what's missing in your care. And then I know you're going to talk a little more about some of the practical ways to access those voices, Darla.
Next slide. So these are some things you can use as takeaways to think about as you go back to your teams and talk about some of the ways you could involve people living with lived experience if you haven't already, or how to add to it and enhance your program. So thinking about who you're serving, because that's important to think about who you're serving and how you can involve them. It makes a difference how to involve them depending on the people that you're serving. And then what's the stigma around your topic? Some of you have mentioned some of the stigma and the weight of stigma. So thinking about that related to your topic so that you can determine how to involve the people. And then thinking about the climate and environment in your communities. We're all very different. Is it rural? Is it urban? In some of my areas, there's a lot of poverty, or they're resource poor, or it's food insecurities is a bigger issue than anything that I bring to them. So thinking about all of those barriers as well. And then how might this be tweaked and implemented in your area? So we asked you during some of the waterfalls, but this is something you can take back as well and discuss this with your teams, thinking about these. I don't know if anyone has anything to add there. We can keep going if they don't.
Right.
Okay, so we have a call to action. Nothing about us without us. We love this quote. People living with HIV have really embraced this. They like us bringing them to the table. They use the terms meaningful involvement as well. And that highlights that we are working on our focus topics and conducting AD. We're doing so on behalf of diverse populations. And asking for their input ensures that we're forwarding their insight to our stakeholders. So we should ask, and then we should listen and react to what the patients are saying. We could support peer-led initiatives. When we build with, not for, we build trust and impact. We feel that's very important. Next slide. Okay, we've been talking about the patient voice. Think about your voice. What parts of your own voice or story will you bring to your AD work? For me, it's 30 years of experience, over 30 years in the field of HIV, STI, and hepatitis. So I have daily the thoughts, the remembrance of things that people have said to me. I bring that to my work. What parts of your own voice do you bring to your work? Love to hear it from you. Thanks, Bevan.
Yeah, and try this filling in this sentence. I will bring my X to my AD work. And maybe tying back even to the values that you identified earlier today. Think about what you'll bring. It can be a tangible resource, like Darla said, experience. It can be something like your integrity and your authenticity. And while we're waiting for responses in the chat, we have some great suggestions. Latricia Gordon says, suggest consumer review committees. It gives the client space to give feedback and make impactful suggestions. Amy says, it may be helpful to have comebacks for when providers, or anyone for that matter, may say something awful. Initially, we can be so shocked that it makes it difficult to say something meaningful and professional. We actually did an exercise on this at a summit prior to have those ready to go, and I will drop a link at some point shortly. Lauren from Saskatoon says it's important to remember that one patient rep does not always necessarily represent all. So consider that there's a range of patient experience. And Deb is sharing an obesity campaign piece that was included. It looks like the hashtag was obesity more than meets the eye. Thank you for that. Christine Fishman says she'll bring her passion. Tahira says bringing past learnings, parentheses, mistakes, trying to keep them in your pocket as reminders because we're all continuously learning. We also have an open mind and humility, youth voices, making sure to include what you hear when you take time to listen to youth and young adults. Really important. It doesn't always match what the data tells us. Yes, sometimes the qualitative and the quantitative tell two very different stories. And we'll wrap up here with empathy, compassion, a listening ear, and a gracious spirit. We're coming right up on time. Darla, I know you had some closing remarks you wanted to share before we transition into a break.
Yes, Mary and I do want to thank all the participants for the great conversation and the waterfalls, and a shout out to the rest of our team, Ashley, Alicia, and Kathy, for all the hard work they do every day. And of course, we thank NARCAD for this opportunity and all the wealth of information that we are getting from them. And before we take any questions, if we have time for that, this is a photo of rural Iowa that a person living with HIV captured. So we began our initiative in 2016 with people asking for us to do some work in the communities. People living with HIV asked for us. And we began the slides today with a photo of people with lived experience at one of the summits in Iowa for people living with HIV. So we end with a photo of a person with lived experience with HIV at their summit last year. And so for us, it begins and ends with the people.
Beautiful. Thank you so much. We really appreciate you all from Iowa doing this hard work, your mighty team of 5. We are coming up on a break. And so if there are any other questions you want to ask, please pop them in the chat. I will triage those over to the wonderful Iowa team. Such a pleasure to have you all kick off our summit with such a meaningful session. Thank you so much. We're going to go into a 30-minute break. You're welcome to stay for the first few minutes of the break to chat with Darla and Mary, and then you'll come on back and choose your program development workshops. The link to this is narcad.org/breakouts, and Vishal will just dropped it in the chat. You can also check out our summit page for more details. Anything else? Mary, would you like to say anything else as we wrap up? Or anyone else from the Iowa team?
No, just thank you all so much, and we appreciate your participation. And again, NARCAD, thank you for having us at the 3rd annual Summer Summit. Just fabulous.
And we have a question from Dave Watt. Everyone else, feel free, if you want to start your break, your half-hour break, please do, but we'll stay for 5 more minutes so that Darla and Mary can ask questions. Feel free to, if you are taking a break, just shut your camera off and stay connected to Zoom. Dave, over to you.
Hey, in the picture, the group picture, did I see Mark S. King in that picture?
Yes.
Oh my goodness, how cool was
Yes.
that to have him?
So I'm fortunate enough to be a friend with him. You know, I've met him at
cool.
conferences. You know, we're not buddies, but I've met him at conferences. And so I actually reached out to him because we focused last year's Wellness Summit on storytelling so that we could capture videos, but teach people how to tell their story first. That's first. Well, who's better at telling stories than a published author who's living with HIV? Mark S. King. And so I said, shy little me, could I really ask Mark S. King to come to Iowa from Atlanta? And he did.
Oh,
he
that's
was
so cool.
Pleased to be invited. He said, why don't people invite me to come? And so he came and he actually, you know, stayed with the patients. He stayed in the dorms with them. He interacted with them, but he also did an hour or so presentation on storytelling and how best they could tell their story so that we could pass that story on. And so, yes, it was very exciting to be able to have Mark there, and what a treat for our individuals living with HIV. And they each got a copy of his book.
Yes.
Oh, wow.
Yep.
Oh,
Brought his
wow.
book, and he helped us
That's
put
really cool.
welcome bags together. Just an amazing person, and what a great experience it was. Yeah.
That is so cool. I just love all of the interconnectedness of this too. Just hearing Darla say like, oh, we learned this from Dish, and Dave, that you know somebody in the picture, and like that just shows what a both big and small world it is and how much community matters. Thank you so much. I love the Iowa team, and thank you, Dave, for wrapping us up with a question. Darla and Mary, thank you so much for being here. And we did start a little early. That was my mistake, but thank you for rolling with it. Really appreciate you. I'm glad we had a lot of time to go through your presentation, like nice and slowly, and just kind of have a lot of breathability and audience interaction. So please take your well-deserved break, and we'll see you back at breakouts. Thank you.
Thanks so much.
Okay, take care. All right. Vishal, break for us, and then I'm going to stop recording.
Alrighty.